السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته. حياك الله أستاذ.
We can start إن شاء الله. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم آمين وأجمعين. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل آمين يا رب العالمين. My first case today, this is my first case. Any volunteer for this case? Any volunteer? Any volunteer for this case? ما حدا بده يتبرع؟ Any volunteer for this case? It is very simple. Any volunteer? I will help you, no problem, don't worry. What is the examination here? Any volunteer for this case? As we see here, this is a hysterosalpingogram for
Assalamu alaikum.
Alaikum Assalam.
Hysterosalpingiography showing bicornuate uterus.
Bicornuate uterus. The left tube is seen or not? Left tube, it is shown here, but not village. Okay. The right tube is not seen because it is the coning of the fluoroscopic spot. It is here. Okay. Other differential diagnosis for this case. We can put other differential diagnosis. This is classic for bicornuate uterus.
The differential diagnosis is septate uterus.
Okay, very good. The differential diagnosis, it is septate uterus. How to differentiate?
We should in hysterosalpingiography, we should measure the angle.
Which angle?
Between two uterine horns.
Between the uterine horns. How you can differentiate between both?
If it is less than 75, it goes with the septate uterus. If it is more than 105 degrees, it goes with bicornuate uterus.
If it is septate uterus, it is partial. Can differentiate with that?
Less than 75.
Less than 75. So this here, less than 75. So it is septate uterus. I think the best best method for differentiation, it is to do MRI. Okay, with MRI you see the
Yes.
septum, you see the septum, and you see how much it is partially septum or by it is complete septum. Okay, sometimes it is complete septum. It is shown in the histosalpingogram as a bicornuate uterus. We cannot differentiate, by the way. So the MRI is the next step for this patient. So here, histosalpingogram showing two horns. One of the differential diagnoses is bicornuate uterus. The other differential diagnosis is septate uterus, and the next step it is MRI. Okay. Okay. Any question for this case? So the next case. Next case, it is also simple, but it is anyone for the next case? What we see here, this is the left hand X-ray and the left humerus X-ray. What we see, anyone?
Start
تفضلي.
X-ray of the hand and the هذه humerus.
Humerus, yes.
Humerus, okay.
Okay. This is the
Uh,
glenoid cavity here. Okay, and this is the scapula, and
there's
these are the
distillated
ribs.
humerus and there's abnormal lesion at the head of the humerus, distracting the cortex or mixed lytic with sclerotic lesion.
Okay. The shaft of the humerus, there is something or not?
Also, there is abnormal bone density involving the medullary cavity of the shaft of the humerus.
Okay.
Or there is also in the hand abnormal increased bone density involving both the first and first finger and the second metacarpal head. يمكن الكيس ميلوريوستوسيس دكتور؟
Huh?
ميلوريوستوسيس؟
Yes, very good. This is a case of medullary. So it is
wax candle wax bone density
candle
أو
appearance or melting candle appearance, giving the this is the okay. This is شو بتعرف يعني what is the medullary?
يمكن X-linked X-linked dominant
Autosomal dominant.
يعني inherited disease.
Non-inherited.
Inherited disease, okay. You have cortical thickening with increased bone density, and the patient may come with chronic pain, sometimes come with contractures, and sometimes come with discrepancy between the length of the limbs, okay? And it is the pain, it is actually following as their said in the box, it is following the dermatomes. مظبوط?
Sclerotome distribution.
Yeah, dermatome distribution. Okay. Any question on of this case? Medullary. Okay, we move to the next case. It is simple. Next case. This is single or double contrast.
barium swallow.
Barium swallow, single or double contrast?
Single contrast.
Single contrast. What you see?
Diverticulum. Zinger diverticulum.
Zinger diverticulum. Where is the here? It is where is the location here?
It is the distal esophagus.
Distal. Zinger diverticulum where?
Distal proximal, I think. This
Yeah,
is
it is proximal in the cervical esophagus. Okay. At the level of C6, C5, C6. Okay. So this is here distal esophagus. What we call that diverticulum?
Epiphrenic.
Epiphrenic diverticulum. What is the type of the diverticulum here?
Pulsion.
Pulsion.
Bulging diverticulum. Can you name the other type of the diverticulum?
Traction diverticulum.
Traction diverticulum. What is the difference between traction diverticulum and bulging diverticulum?
Pulsion diverticulum occurred due to an increased intraluminal pressure, such as in achalasia.
غالبا bulging diverticulum usually occur due to inflammatory or fibrotic changes, and it is in the mid-esophagus. Okay, and the difference between bulging and traction diverticulum, this is a false diverticulum. Not all the layers of the esophagus it is included in the diverticulum. In the traction diverticulum, it is a true diverticulum, and it is include all the layers of the esophagus in the diverticulum. And here, the bulging diverticulum, it is located in the distal esophagus, as we see here, it is epiphrenic diverticulum, or in the upper esophagus, as we see in the Zinger diverticulum. And the traction diverticulum, usually it is in the mid esophagus. غالبا and it is commonly due to TB adenitis.
TB.
Yeah, okay. Okay, any question? Anyone can mention the diverticulum, name of the diverticuli in the upper esophagus other than we mentioned Zinger, and other what is the other name of the other diverticulum?
Killian Jamison.
Killian Jamison. Can you know the difference between the both? The difference between Zinger, it is posterior diverticulum.
Posterior, yes.
Yeah, and Killian Jamison diverticulum, it is anterior lateral, okay?
Anterior lateral.
Anterior lateral diverticulum, and this is the location. And the location, the Zinger diverticulum, it is higher than the Jamison diverticulum. The Zinger diverticulum, it is at the level of the cricopharyngeal muscle at the C5, C6, and the Killian Jamison, it is little bit down, okay, at the level of the thoracic area. Okay, any question for the diverticuli of the esophagus? Okay, we can move to the second case. Next case, what is also related to the esophagus, what we call this type of
pseudodiverticuli.
It is a pseudodiverticuli. Okay, you can mention the full name.
Flask outpouching.
No. I mean the full name of the pseudodiverticulosis. It is type of pseudodiverticulosis, but you should put one word before the pseudodiverticulosis. What you can put?
It occurs in reflex esophagitis.
No, this is the cause, one of the causes, yes.
Yes.
It is intramural pseudo-diverticulosis, okay? Intramural, okay?
Candidiasis, esophageal candidiasis, one of the
Also,
definitions.
any infection can cause, okay? It is any infection can cause peptic ulceration, candidiasis, even carcinoma can cause,
Cancer.
okay? Even
Yes.
carcinoma can cause, okay? And these are multiple intramural diverticulosis, pseudo-diverticulosis, and usually it is in the mid-esophagus, huh?
Yes.
Okay, so we see two types, we see epiphrenic diverticulum and intramural pseudo-diverticulosis with this case. Next case, any question for this? Okay, I think it is okay. This case, this is post-operative, this patient, and we need, if anyone can spot the diagnosis.
Foreign body
Where?
in the bladder region. In the bladder region.
Bladder region. Foreign body, make it more specification, more specified.
Gauzy boma.
Pelvic, pelvic cosibioma. Pelvic cosibioma.
Pelvic cosibioma. Very good. This is gauze. It is left in the post-operative, and this is the gauze in the left side pelvis. The patient has some abdominal pain and with some gaseous distension. Very good. Very good. Pelvic cosibioma. Okay. So next case. Okay. We need here good, very nice description for all the findings. Okay.
X-ray of the shoulder showing
X-ray of the shoulder. Okay.
Showing lytic lesion involve the head of the humerus.
Okay.
I think it is a permeative lesion, Doctor.
Okay.
Because there is industrial يعني irregularity, multifocal industrial irregularity, with also some of the cortical destruction involving the lateral aspect of the humerus head. Or it is periosteal reaction.
Okay. لو حكينا إنه this case there is no bony destruction as you mentioned. Okay. There is no bony destruction as you mentioned. What is the position of the humeral head here? It is
upward.
Upward. What we call that?
Subluxated يعني.
Okay, subluxated or upward widening of the humeral head. Okay, so the distance between acromion and the humeral head is decreased. Normally, how much? About 5 to 6 millimeter.
I think 8 millimeter.
5 to 6 millimeter. Okay, so and here as you see the bony, it is looks like osteoporotic. مظبوط ولا لا?
Yes.
And
rheumatoid arthritis.
And okay, we need the differential actually, and the joint space here between the joint space
Decreased.
also narrowed, but it is narrowed symmetrically narrowed, not looks like osteoarthritis. Okay, مظبوط ولا لا?
Yes.
Okay, not like osteoarthritis. It is not osteoarthritis. Okay. What about the clavicle? Any finding in the distal clavicle?
It's resorbed.
Yeah,
distally.
it is resolved. Distal clavicle, it is resolved. So combine all these findings together. What are the
Rheumatoid
differential
arthritis.
diagnosis?
high riding
First, rheumatoid arthritis.
high riding scapula.
لا scapulitis اوكي يعني والديفرنشال diagnosis one حكيته انتوا اول واحد حكيته اول واحد
Rheumatoid arthritis.
rheumatoid arthritis. Other differential diagnosis
rotator cuff tear.
Rotator cuff tear. Okay, very good. Complete rotator cuff tear. Other differential diagnosis?
Also
hyperparathyroidism.
Hyperparathyroidism. One of the main differential diagnosis. Okay. Other differential diagnosis?
Calcium pyrophosphate deposition disease.
No. But post-traumatic. Okay.
Post-traumatic.
Post-traumatic. Could pre-metastasis give the appearance?
Maybe.
No.
Maybe, yes. Maybe metastasis give the appearance. And this case, it is rheumatoid arthritis. Okay. So this case, it is. Can one summarize the finding here? What are the findings?
Narrowing of the joint space of shoulder joint space with also sclerotic subchondral sclerosis and generalized decreased bone density in the medullary cavity with the narrowing of the space between the acromion and the humeral head. And high riding or subluxated humeral head.
And ما حكيتي على clavicle, resolving of the distal clavicle. Okay?
Yes.
Okay.
Yes,
These are the differential diagnoses. Okay? Sorry, these are the main findings. And the differential diagnosis, we put hyperparathyroidism, rheumatoid complete rotator cuff tear, post-traumatic, and even metastasis. Okay? And the case here, it is rheumatoid arthritis. Okay? Okay, we can move to the next case. This patient for liver transplant, and this is the angiogram for the patient before the. This is donor angiogram before the operation. What is the finding here?
CT angiography.
CT angiography. Can you name the technique?
Rendering.
Okay, this is volume rendering technique here, and here
showing the aortic branches.
This is اللي عليها صح. ايش هذا التكنيك؟
coronary formatted image.
This is coronary format, but it is MIB. Okay.
Yes.
It is MIB. Okay. What you see? What you see, huh?
There is the branches of the celiac and subclavian artery.
Okay.
Common hepatic artery.
Okay. What is this? What is this branch? اللي عليه الإشارة هسه هذا. What is the name here?
Splenic artery.
This is a splenic artery. Okay. واللي عليه السهم اللي نازل لتحت.
Right gastric?
No.
Hepatic.
Left hepatic.
Okay. Common or proper hepatic. Okay. And this one.
The right hepatic artery looks originated from the superior mesenteric artery rather than.
Okay, very good. This is the right hepatic artery originated from the superior mesenteric. Okay, and this one here, what we call this anomaly? It is إيش?
Replaced.
It is replaced hepatic
Hepatic
artery from the superior. Okay, what is the name of the artery here اللي عليه السهم هذا؟
Gastroduodenal artery.
هذا gastroduodenal artery. Okay, and this one هذا عليه السهم
Left
إيش
hepatic.
اسمه؟ ها؟
Left hepatic.
Left hepatic, and this one
Right hepatic. لا هذا
this one
Left
left gastric.
gastric.
Left gastric artery. So here, this is the celiac axis here, and this is the splenic, the proper hepatic, okay, and this is the left hepatic, left gastric, and the right hepatic from the superior mesenteric. It is replaced, and we see it here very nicely in the MIP images. Also, we see it in the volume rendering, and this is the superior mesenteric artery here. Okay. Okay, any question for this normal anatomy or normal variant? Okay, next case. Next case. Next case, what we see in the next case.
احكي انا حكيم.
تفضل.
Okay, this is a scout imaging or a frontal projection X-ray for the abdomen and pelvis, showing a bulging or an out bulging seen involving the left lateral aspect of the abdomen. I think this out bulging contains foci of gas outlined in a bowel fashion. You know, it seems like a bowel. So my differential, or what I think of is a hernia with the containing bowel. I think they are large bowel. I'm not sure.
Okay, which type of hernia you think here?
I'm going to say Spigelian, maybe.
Spigelian. Okay, why Spigelian? Spigelian بتشوفها lateral? You see the Spigelian hernia lateral on the lateral aspect of the body? Or in the
pyramid line. Pyramid line.
Lumbar hernia.
It is
Lumbar
a lumbar
hernia.
hernia. So this is a lumbar hernia. How to confirm it? على
ممكن ultrasound أو ممكن CT.
ممكن ultrasound and CT. Okay. Here we have مشانك أعطيناك sorry CT ها شو رأيك؟
Okay.
كمل.
Yes, I'm Ashtash. Okay, the CT confirms the prior finding by showing a hernia or a hernial sac seen involving the left lateral aspect of the abdomen, containing large bowel loops, omental fat, vessels, also vessels. There's a stretching in the corresponding fascia, I think, or abdominal muscles.
Okay, where is the hernia located?
ممكن نحكي abdomen and flank, maybe left lateral abdomen.
No, how many قبل ما هاي how many types of lumbar hernia you know?
Lumbar hernias.
There is two types of lumbar hernia, superior and inferior. The superior is more common than inferior.
Then we have two types of lumbar hernia, the superior one and the inferior one. And here, this is inferior or superior?
Not sure.
Here, this is the inferior because it is the superior, it is about in that area, and this is the inferior one. As she said, the superior one is more common than the inferior, okay? More common than the inferior one.
Okay.
Okay, can you name the inferior hernia? شو اسم اللي سماها ولا صعب؟
Petit hernia. Petit hernia.
Petit hernia. It is petit hernia. Okay, very good. And superior one, can you remember the names ولا بلاش؟ اوكي صعب الاسم صراحة.
I'm not sure ما بعرف صراحة.
صعب الاسم. اوكي. جرينفيلد ليسهافت hernia. جرينفيلد شكله ألماني. Okay. So this is the lumbar hernia. Okay. Probably in the inferior part and containing bowel. It is بدك تعلق لما تعلق you should mention that the hernial sac, it is wide here, okay? And it is no signs of obstruction and no signs of strangulation, okay?
Okay.
You should mention that because sometimes the patient can be presented, especially with hernia, different types of hernia can be presented with obstruction, with pain. It is depend on the what is located in the hernia. Okay.
Okay.
Okay. Very good, Ala. Very good. Any
you.
question for this lumbar hernia? Okay, we can move to the second case, our next case. Here, what is the type of injury, huh?
I think avulsion maybe, avulsion fracture.
Avulsion fracture. طلع عليها مظبوط يا علاء. Anyone? Anyone? What is the type of injury here?
Intra-articular?
Any type of injury here? Anyone? Here, this is normal. No injury. Okay? This is normal. This is the apophysis of the fifth metatarsal bone here, and you see it vertical in position. So what is the type of injury? As he said here, there is no injury. There is no injury because this is a normal apophysis. Okay, so this is normal. Okay, this is normal. Okay, ولا مش okay?
Okay.
Okay.
Okay, so this is normal. You should differentiate it from a avulsion injury. Okay, you should by vertical line, because it is oriented in a vertical fashion. So this is a normal apophysis, and there is no injury. But what about this one? Okay, this is as he said. It is vertical or sagittal oriented, so this is a normal variant, okay? Not to be mistaken by avulsion injury. What about this one? What the type, what is the injury here? It is injury or this is normal also here?
Sesamoid bone?
Why sesamoid bone?
Well corticated piece of bone يعني
طيب,
there is
okay,
no...
well corticated, but you see the sesamoid bone not like this. في sesamoid bone in that area. مظبوط ولا لا؟ In that area, there is sesamoid bone. Can be multipartite, unipartite, bipartite, in that area. What we call it? Osteomatosis, okay? In that area. But here, this is not sesamoid bone. What is this? This is
avulsion fracture.
Avulsion injury, okay? This is avulsion injury. What is it is attached here?
Peroneus brevis.
Peroneus brevis, okay. Other than peroneal brevis muscle?
The fascia, I think,
Fascia,
of the
very good.
plantar aspect of the foot.
Yeah, okay, very good. This is a plantar fascia. It is attached here. So this is a avulsion fracture. It is a avulsion fracture in that area. Okay? Okay. طب what about this one? أنا جمعت لكم إياهم الثلاثة مع بعض أو الأربعة مع بعض. What is the type of injury here?
Jones fracture.
It is a avulsion fracture again. It is a avulsion fracture.
It is avulsion, yes.
Yeah, it is a avulsion fracture. But what is the avulsed area here?
Muscular tendon?
It is tendon. Which tendon? حكيتوه قبل شوي.
Peroneus brevis, I said
Peroneus
previously.
brevis, very good. It is Peroneus brevis. The difference between Peroneus brevis and the plantar fascia, the avulsion fracture in the Peroneus brevis is larger than the plantar, okay? Plantar fascia. So you see here, this is small, and here this is large. And this one, it is intra-articular. And this one, it is intra-articular with Peroneus brevis muscle, okay? So this is a avulsion fracture of the Peroneus brevis tendon. And as we said here, the differentiation, Peroneus brevis, it is intra-articular fracture, and it is larger than the plantar fascia. Okay?
It is called pseudo-Jones fracture.
Pseudo-Jones fracture. Very good. And the fourth one, okay, this one.
Jones fracture.
This is Jones fracture. It is 1 centimeter, 1.5 to 2 centimeter away from the base, and it is some sort of, this is Jones fracture. It is beginning as a stress fracture, okay? And it is other name of Jones fracture. حدا بيعرف؟ Dancing
fracture.
Dancing fracture, okay? The treatment, as we إذا بتتذكروا سابقا احنا فرجينا كيس it is a treatment, it is surgical in most cases, okay? Internal fixation. Okay? So repeat, because these are important. This is no injury. This is normal apophysis. Okay, normal apophysis. Vertically oriented. Okay, vertically oriented. It is normal apophysis. Here, transverse. avulsion fracture. Small one, it is due to plantar fascia avulsion. Larger one, it is peroneus brevis tendon avulsion, and it is larger than the first one, plantar fascia, and it is intra-articular. And the third one, it is Jones fracture, and it is about 1.5 to 2 centimeter from the base, and it is treated surgically. Okay, and it is also called dancing fracture or dancer fracture, whatever you like. Okay, and it is started as a stress fracture. Okay.
Okay.
Okay. This case, هو أنا حطيته بجوز بالغلط. Okay. Okay, this case, we have that central line. Okay. ماشي. And this is after 12 hours for this patient. Okay. What is the difference? Anyone? What is the difference between the first one and the second one? Sorry. Look at the mediastinum here. There is normal mediastinum here in that area. Okay. Here, what you see?
Wide mediastinum.
Wide mediastinum. The time between both X-rays is 12 hours. What is this?
Mediastinal hematoma.
Mediastinal hematoma after insertion of the central venous line. This one, okay? Sorry. So this is mediastinal hematoma. Also, we should look for what?
Pneumothorax.
Pneumothorax, very good. في pneumothorax ولا ما فيش؟ ما مبين يعني هون عندنا إذا كان في small horn we don't have any visual pleural seal. Okay, so this is mediastinal hematoma after insertion the central venous line. Okay, this is a spot diagnosis.
Neurogenic bladder with bilateral reflux.
ها؟ علي صوتك ما سمعتش.
Posterior urethral valve.
Wide posterior urethral valve.
Urethrocoel, bilateral.
Bilateral urethrocoel. It is very simple. Okay.
Cobra head. Yeah.
Cobra head appearance. Bilateral. And this is post evacuation film of the IVU. This is the post evacuation film of the IVU, and you see bilateral urethrocoel. What is the type of urethrocoel here? Simple or not? Huh?
It's not bifid.
It is not
It's
bifid.
simple.
It is simple. Okay.
Yes.
It is simple urethrocoel. Okay, very good. Okay, this case. This is IVU, okay? Spot view at the distal ureter and urinary bladder, okay? Here the bladder, okay, the bladder. The
Pelvic
bladder
labomatosis.
orientation, it is عاجبكم bladder orientation?
Pelvic lipomatosis.
Pelvic lipomatosis, very good. But تعرفي حاولي توصفي لنا إياها ماشي؟
Okay.
Pear shape bladder.
IVU
IVU, okay. Spot
showing
view,
pear-shaped bladder.
okay.
Large conical shape.
Okay, the bladder is vertically oriented here and it is squeezed from the both lateral aspect, okay? Suggestive of, and it is base, it is
Pelvic lipomatosis.
pelvic lipomatosis, okay. And how to confirm that? How to confirm that?
CT scan.
CT scan, what you see?
CT scan.
What you see CT scan?
Extensive deposition of fat.
Fat.
Okay, extensive deposition of fat. You see it is a fat, too much fat in the pelvis, in that area, and around the rectum, okay? And around the bladder base. So this is pelvic lipomatosis. What are other differential diagnoses?
Hematoma.
Hematoma, very good. Other differential than other than hematoma?
Lymphadenopathy.
Lymphadenopathy, very good. Other than lymphadenopathy?
Mass, we can.
Any mass, but bilateral. We want bilateral. Okay.
Ovarian mass, bilateral.
Ovarian mass, bilateral, aneurysms, internal iliac aneurysm, bilateral, collaterals, okay, and the inferior vena cava obstruction. Okay, these are the differential, some of the differential diagnoses in this of the pelvic lipomatosis. Okay, vertical bladder. Also, they call it teardrop bladder, okay? Okay, this case, simple case, مو صعبة. If you can spot it, very good. وبعدين بنحكي عليها.
Rectic rosary.
Rectic rosary, no.
Osteoporosis.
Osteoporosis, okay. This is osteoporosis. Other differential?
Fluorosis.
لما نحط بالأولاد الصغار in the child أو neonate in the child
Pycnodiastosis.
pycnodiastosis, okay. Pycnodiastosis. Okay, pycnodiastosis, because we don't have hands, okay, we don't have hands, so we should put osteoporosis and pycnodiastosis, okay? Okay, how to differentiate with both? With the hand, okay. With the hand there is
Acrosteolysis.
acrosteolysis بالبيكنوديستوسيس, but بالاستيوبوتوسيس there is no acrosteolysis. What we call this sign here?
Roger Jersey spine.
Roger Jersey sign, okay, very good. Roger Jersey ولا ساندويتش vertebra ها؟ شو رايك؟
Sandwich.
Sandwich,
Huh?
sandwich.
Sandwich vertebra, okay. Okay, this is osteomatosis. طبعا it is inherited disease and it is autosomal recessive. Okay, a patient sometimes come with anemia, fracture, even صح
bleeding disorder.
and the bleeding disorder. Okay, anemia and the bleeding disorder. صح, the bone it is sclerosed, but it is brittle bone. يعني okay.
fragile.
Fragile, أو fragile, the same terminology. Okay. Any question of this case? Okay, طلعوا على الكيس هاي دقيقة وأني جاي. أوكي دقيقة شوي. Anyone spot the finding? Hello? Anyone spot the finding? Anyone see the finding? Hello? Hello?
There is a fracture of the left occipital condyle.
Okay, very good. On which side?
Left.
Huh?
Left.
Left side. This is the fracture line here. Very good. And this is the fracture line on the axial cut. So this is a fracture of the occipital condyle on the left side. Okay. It is important to see. Okay. If you don't know what to look, you will not see it. Okay. This is common fracture or uncommon fracture? It is uncommon fracture.
Usually follow a violent trauma.
Huh?
Follow a violent trauma, so it is uncommon.
مش سامع.
It follows violent trauma, so it is uncommon.
Uncommon fracture. Okay, this is uncommon fracture. Okay, so this is a spot fracture line on the left occipital condyle. Okay. Okay, this case. What is the procedure here? What is the procedure here? Okay, this is T2. So this is T2 coronal image for the abdomen. Okay, what you see? This is coronal T2 image for the abdomen. What you see? We see here the spleen, we see the liver, and we see the kidneys, and the pathology in the kidneys. What we see in the kidneys?
Multiple tiny cysts or cystic-like signal intensity.
Multiple tiny cysts involving both kidney.
Both cortex and medulla, evenly distributed, seem to be bilateral and symmetrical.
Okay, what is your diagnosis?
Drug-induced.
Sure.
Drug caused by drugs.
It is caused by drug. You know the drug?
Lithium.
Lithium, very good. This is lithium nephrotoxicity involving the kidney, and it is multiple tiny cysts. How to differentiate it from the chronic renal disease?
Chronic renal
Normal.
disease, there is associated with the parenchymal atrophy, kidney atrophied.
Okay, here with lithium induced nephrotoxicity, it is the kidney size, it is normal. Okay, and the kidney size, it is abnormal, it is small, and here the cysts are as you said, uniformly distributed. There it is different in sizes. Okay. You know what is that drug used for? What is what is
For
used?
stabilizer, bipolar disorder.
Treatment of psychosis.
Antipsychotic, I think, antipsychotic disorder.
Antipsychotic for bipolar.
Ticket drugs, يعني, I think. Yes.
Bipolar treatment.
Mood stabilizer, yes.
No, bipolar treatment. Bipolar conditions. Okay. Okay. Any question for this? And we move to the last case. Okay. Sorry. What happened? Okay. This is our last case for today. Okay, what is, describe the findings and in the description, very good description.
Lateral view, plain X-ray of the knee joint.
Lateral X-ray of the knee joint showing?
Showing total knee replacement.
Total knee replacement, okay.
With the linear soft tissue calcification at the posterior aspect of the knee.
Posterior aspect of what?
Of the knee.
Of the knee.
Extended to the lower thigh.
What is that?
Heterotopic ossification.
ايش هو؟
Myositis ossificans.
طلع عليها مظبوط. What is that? Any visit in that area?
Vascular. Yes, the popliteal.
Vascular calcification.
Okay, vascular calcification, it is popliteal artery calcification. Okay, this is a popliteal artery calcification. More description on the popliteal artery calcification on this case. Where is the calcification? Where's the calcification? It is associated with aneurysm or not? And is there any luminal narrowing or not? You can answer these three questions.
There is aneurysmal dilatation at the upper part of the image.
Okay, there is aneurysmal dilatation here, okay? And there is aneurysm here and a little bit dilated here, okay. Where's the calcification? Where's the calcification?
Mural calcification.
Which layer?
Intimal.
Which layer?
Intimal.
Intimal. Are you sure? Intimal. If it is intimal, it will cause narrowing of the lumen. مظبوط ولا لا؟ مظبوط, because it is atherosclerotic changes. And you see here, the lumen looks like it is okay, huh?
Yes.
It is not narrowed. So the calcification, it is not in the lumen. The calcification, it is in the where?
Adventitia layer?
Adventitia and media.
Adventitia layer?
And media, okay? Okay, no, anyone knows the name of this type of calcification?
I'm not sure.
Dystrophic calcification?
No.
Mockenberg, I think.
Okay, very good. It is a Mockenberg calcification, medial calcific sclerosis. It is involving the medial layer of the artery, of the medium-sized arteries, and this is Mockenberg calcification. M-O-N-C-K-E Berg, B-E-R-G. Okay.
Yes.
What
Yes.
else?
Patella is abnormal.
Patella is abnormal. Very
Abnormal.
good. Okay, patella is abnormal. It is very
Increased
good.
density.
We have condylomalicious changes. Okay, ما جاوبناش السؤال. Is there any loosening around the knee replacement?
No.
No, there is no loosening.
No loosening around the knee replacement. Okay. So in summary, what we see. حدا يلخص لنا إياهم؟
Okay, this is a lateral X-ray of the knee joint,
Okay.
showing total knee replacement with no evidence, radiographic evidence of loosening.
Okay.
There is also calcification in a linear fashion seen involving the media of the popliteal artery. The patella also is فيها يعني
كمل وصف على البوبليتيال artery. Okay. كمل.
Popliteal artery atherosclerotic changes seen involving the media and adventitia with aneurysmal dilatation of the proximal portion of the artery.
Okay.
No narrowing.
Patella is abnormal.
Patella. Okay.
Yes.
Okay. How often it is popliteal artery aneurysm associated with abdominal aortic aneurysm? MCQ question.
20?
More. It is about more than 60%. Okay, more 60 to 70% popliteal artery aneurysms are bilateral and associated in about 30 to 50%. Okay, bilateral popliteal artery aneurysm about 60 to 70% and associated with abdominal aortic aneurysm in 30 to 50%. Okay, and it is common in male. It is common in male.
Yes.
Okay.
Yes.
And there is very rare distal thromboembolism from these, because it is not in the lumen, because it is simple. Okay. Okay, any question on this? So no narrowing, medial calcification, bilateral in about 60 to 70%, 30 to 50% it is associated with abdominal aortic aneurysm, and what? And common in female. Okay. I'm sorry, common in male. In male.
Okay.
Okay. So this is for today, and inshallah نشوفكم الأسبوع الجاي. Any question for this?
يعطيك العافية.
يعطيكم العافية. تصبحوا على خير إن شاء الله.
شكرا بارك الله فيك.
شكرا دكتور بارك الله
مع
فيك.
السلامة في أمان
بارك
الله.
الله فيك. تصبح على خير أستاذ.
يعطيك العافية حكيم.
مع السلامة في أمان